Hello, everyone. I'm here to make a presentation on thematic dashboards we have for the NMDR dashboard. So, my presentation will follow this outline. We would like to look at participants' objectives, introductions, then we now launch into the live demonstration of the dashboards on the NMDR system. Then we go through the practice exercises we're meant to do at the end of the module. So, as a way of objectives, at the end of this module, participants should be able to have understanding of the fundamental concepts and then practical approaches to use the dashboard on the malaria data repository. And we also have to discuss how the analytics displayed on the dashboards can facilitate the use of data for decision making and also demonstrate how to do drill down function to go to the org unit you will get to use data and make decisions, and also understand some of the illogical data being reported through the national instance of the DHIs. And at the end of the day, with the when you attempt to do the exercises, you will have like a hands-on experience using the NMDR. So the next, I think, by way of introduction, you will understand that dashboards are intended to provide quick access to different analytics, such as the map, views, charts, tables, and based on this, we design dashboards that would speak to each of the thematic areas we have in the program. So we have six dashboards. That's first one is the prevention tracking indicators that reports on prevention. So literally data coming from the routine indicators we track that has to do with the uptake of lines and then sulfurdoxine pyrimethamine, and then we have data that also had the line campaign tracker. So we also have case management, basically tracking those services being provided for clients or patients that present with fever, got tested, and we track to see what is the test positivity rate and then the treatment uptake of ACTs. And we also have surveillance that actually provide us with health facility ownership level of care that we do use as we track data under the National Health Management Information System. So we do also have data that speaks about the morbidity and mortality of the disease. So we have prevalence data, we track hemoglobin data, we also carry out drug therapeutic efficacy study to understand what is the efficacy and effectiveness of the drugs we use as first line. And we also have data that dashboard that speaks about the health system. That's the expenditure of the funding, something that has to do with how strength of the capacity building and the malaria funding in the program. We also have a data validation, as I rightly mentioned in the definition. We track data that has to do with presentation from the DHIS to actually analyze and see data being reported to the data be of good quality. That's to say, you shouldn't expect a data that fever aggregation to be more than the OPD attendance because it's supposed to be a subset of the OPD attendance. The same thing with testing and fever. Testing is not expected to be higher than the fever presentation because it's among those that present with history of fever or fever at presentation that they got tested. The same thing with those that are confirmed and then got tested and etc. etc. So this is we're trying to launch into now going into the live demonstration. As you can see, this is a platform where you would once you get the URI link, the live link, you would just click here to get you into having to access the data. So we do have a platform where it would allow you once you have the login details to sign in using your username and password, then it will allow you go into the platform. So I'll just go in directly. So we have, as I've mentioned, we have prevention, case management, surveillance, morbidity and mortality, health systems, and the data validations. So we are now in the prevention. So the first indicator to look at is percentage of ANC first visits receiving line. So we now did a trend that shows a 13-month trend data from April 2019 up to May 2020. And you can appreciate the movement and uptake between 35%, an average of up to about 40%. So just beside that chart, you would also see a disaggregation. This is April 2020 data. So if you have April results of 42% uptake, this is what constitute or disaggregation of states that contribute to this 42%. So you can see Adamawa State having topping the chart of 88% uptake of LLIN during pregnant women attending ANC. So you can see whereas if you go to Lagos State, you will have a score of 1.2% uptake of LLIN in ANC clinic. So moving into the next chart, you will see percentage of 1 to 5 children receiving L-line. The same thing, that's the immunization clinic. You can see an average of about 40%, similar to what we've seen in among the pregnant women. So the same thing, this is an April data, so you can see a 40% average would now constitute that Gombe State is reporting an average of over 100% uptake. You can see Katsina State reporting 96%. The same thing when you come here, you see the lowest states have been Bielsa. Then second to the state, we see Plateau State with less than 1% uptake of children that are fully immunized receiving LLIN. Next chart, you will see that this is a display of percentage of ANC first visit receiving first dose and second dose of SP, that's the IPTP 1 and 2. So the blue line here, the trend represent the IPTP 2, while the light green line represent IPTP 1. So as you can see, it's like a pretty stable trend that has about 60% for the IPTP 1, then about 52% for the IPTP2 over the period of the 13 months. So if you looked at data uptake of 53% in April, the disaggregation, you can see some states actually have more than 80% uptake. When you do compare with what the national strategic plan tracks, you see they are on track. But if you do look at other states, they are tracking as low as presenting 14% in Enugu State, and we do know presentation Benue State having 26%, and then Ikiti having 30%. These are the ones that present. So we do also have a table that display like an LLine implementation tracker. We are discussing with the IVM team to give us other indicators or other display that we can put this data. So, but this is just a summary of how to look at population based on household mobilization. That's mobilization data. Then we now looked at LLIN available for distribution. Then actually those number distributed for 2017 and 2018. We are working to also update this data to 2019. Then the post-campaign LLIN balance, and then how many personnel were engaged in the states that we carry out this campaign. So moving into the case management dashboard, you would now see that, as I rightly said, capturing the continuum of care, presentation with fever in the OPD as the first chart. So you can see the blue line, this is an absolute number of fever attendance to the OPD. That's number of clients or patients attending services through the outpatient department. Then you can see the other red line here, the lighter red, represent the fever as a percentage of presentation to the OPD. Then the dark red is under 5 presentation. So as you can see, the trend of fever with a slight seasonality when you see data from last year, June, July, it gets up, then comes down. But then you just need to ignore May data because it's not yet due. So, but I think because we do like a live sync from the DHIs, we'll still receive the data into the platform. So, but you can see data for April 2020 is about 3.1 million clients stroke patients presented to the OPD, comparing with what we have in April 2019, you see 3.7. Perhaps the issue of COVID has disrupted services slightly. So then the same pattern, you can see the state disaggregation in April. There is a presentation of fever, almost 86% of those that are presented to the OPD are fever in Ebonyi State. Whereas if you come to River State, you only have 26% of those that are presented to the OPD to be fever cases. Then moving into the next chart, this is testing rate, where you now have those that actually have fever at presentation or history of fever, and how many of them got tested. So the blue line represents the absolute number, whereas the red now represent the uptake of testing. So you can see we're doing pretty well here, almost a percentage of more than 90%. As you can see in April, we achieved 92%, but literally as we do compare data for 2019 April with 2020 April, you see that there is a slight increase in number of fever, and then that got tested also 92%. So I think where the uptake too is good. So when you looked at the state disaggregation, you will also see Nasarawa State having an uptake of over, almost 100%, 99.7. Then you can see Enugu State have like an uh, uptake of 58%. The good thing about it, these are states that we could say that for now they don't have donor support. So literally, this is a contribution of how procurement of RDTs would be the cost of what we have, like would say relatively low uptake of testing. So moving into the next chart, it is showing us test positivity rate, which literally means those that got tested and how many of them with suspected malaria turn out to be confirmed. So you can see that we display this chart with the two test types that's either tested with microscopy or the MRDT. So the blue line here represents those that got tested with microscopy and confirmed to have malaria, and then those tested with RDT confirmed to have malaria. You can see the trend is pretty stable over the years, an average with the RDT of about 72% for the 13 months from April 2019 to April 2020. So you can see state disaggregation of how we see the display of the data. So some of the things we now connote in trying to interpret this data is when you see distribution of what we do using the survey of malaria indicator survey or the demographic survey. The last we had was in 2018. You would understand that Delta State have had prevalence of about 16%, but they are presenting with test positivity rate of almost 86% or 87%. So this now make you to have a concern in trying to understand what actually present. Even though yes, Ikiti present of over 80%, and when you do a trend, you will understand that yes, Ikiti prevalence didn't change much. So you would expect, even though not completely, that they could present with higher test positivity rate. But then Delta State has like shown a significant decrease when you compare their data from 2015 to 2018. But then if they're reporting test positivity rate of 86, you will want to find out what is actually driving this high test positivity rate. So this now makes us to move into displaying how to do the drill down function to understand. So we want to find out what's happening in Delta State. You go quickly, you select the state. So once you select the state, you come to the level. At which level do you want to see? Once you select the state, you want to see at LG, then you now press the confirm button here. So every data set on this page will change to Delta, even the trends and the charts, everything here. So we are now interested in looking at the test positivity rate. So you would see that an LGA presenting almost 100%. That means all suspected malaria tested in this LGA turned out to be positive. So you want to find out what is actually the driver here, and it's in the month of April. So you go quickly to Udu LGA, you come back to add filter, and you go to organization unit. And once the data get boot, so you quickly do a drop down to go to that LJ. The LJ is Udu LJ. You select that. Don't forget to come and deselect the state because you want just display of that LJ. But at this moment, you want data for ward. So you deselect the LJ as well, then select the ward. So you now click confirm, and the old information on this page will also get updated to Udu LJ. So we are now interested to see data for the word. So in each of these words presented by in Udu, you will see that almost the 7 or 8 of the words have 100%. That all patient tested have they suspected to have malaria are confirmed to have malaria. So you just take at random one of the words you want to find out what is actually the driver, how many facilities are reporting, and what are the cases. So the first word here is a larger word. You go back to your drill down function, go to the org unit under add filter. You quickly go to the LGA, you do a drop down to go to the words. So we want to see a larger word, the first word here. Then you now deselect the state and then forget to come and change the level. At this moment, you want to see the health facility level changes. You quickly click and then it takes you to, so we were interested in test positivity rate. So as you can see, it's only one health facility driving that 100% test positivity rate, and you would see from the trend, you almost all of the data is being tested using microscopy. You can see no data displayed by RDT, so it's one month of the month of July, whereas it's like they test 10 and 10 out of 10 turns out to be positive. So you would quickly find out what is happening in this health facility, whether or not is even the correct information being entered by the LGA officers. And you can see there is a facility on that is ward, which is the Leonia. They are not even submitting anything here. So this will now allow you to quickly follow up to understand whether this data is correct. Because if it's not correct, then it's making the whole test positivity to be on the high side. So this is just one example. You can go through all the words to understand what's happening. So we're moving into the next chart, which is the proportion of clinically diagnosed malaria. So you can see this has been like a downward trend from 13%. So we have like 11.9% in April. So you would also understand that okay, there's a shoot here, perhaps data quality issue, but then that would now tell you how many that got tested for malaria clinically, and you can see some of the states that contribute high number of testing due to clinical presentation. So Borno State, you can see, then the next state is Enugu, FCT, and this is it that they don't have RDT to use for testing for malaria. And yes, most of the states topping the chart here are states that don't have partners support, and there is something that has to do with stock out of RDTs in those states, perhaps. So you can now understand, make decision quickly if there is a need for you to do a follow-up. The next chart is testing rate by the test types. As you can see, the percentage of those that got tested by RDT in the month of April 2019 are 86% compared to 13% by microscopy. As you move along, this is what it changes. As you can see, the number keeps on having more RDT than microscopy. So we're now moving into the treatment section where we do have uptake of ACT after being confirmed to have malaria. The blue line as it's an absolute number of those that tested positive confirmed for malaria, and then the uptake of ACT is the red line. So you can see the states that actually contribute highest. Kaduna in April 2020, 100% of those that tested positive for malaria received ACTs, followed by Kogi State, also 100. Then we now have Jigawa, also 100. But when you go to the down, you can see the last state here having to be Enugu State. We have Ikiti also, and we have Sokoto. The good thing about it is once you see a low uptake among a state that have a donor or partner support, then it now have to send signal to say what's actually the problem. So Sokoto State happen to be that fall among that states that have a donor support, but they are having to occupy the last three in the country, even though the uptake is 70, but it's below the average. So you quickly do a drill down to understand what is pushing a low uptake. Is it stock out, or is it that there is a reporting issue in Sokoto State? The same process, you go and click on Sokoto. This time around, you want to see data by LGA level. So you don't forget to deselect the national. So you click confirm. So you are now interested in looking at the data from Sokoto. So this is the uptake of ACT in Sokoto by LGA. So you could see that the last LGA, or the second to the last, is Goronyo, with less than 50% uptake of ACTs for the confirmed malaria. So you quickly go and find out what's happening in Goronyo LGA. So you go back to the drill down function, select org unit, and then go and do a drop down under Sokoto because you are interested in Goronyo LGA. You click and you want to see the data by ward as well. So you quickly click confirm and go back to that same chart. You would see that almost four LGAs are presenting 100%, but then others are also presenting 6%. So you want to see what's happening in Goronyo ward. So you quickly go back to do under the add filter to understand what's happening under the ward that they are having an uptake of 6%. So you do a drop down here to go to Goronyo and then click on this and deselect, and you want to see the data by facility. You quickly select facility and then click confirm. So as you get here, you will now see that some facilities are presenting with half of who they present with confirmed malaria are being treated, and some are having no, they didn't treat anyone that has a confirmed malaria with ACT. So as you can see, it could just be a data issue. Maybe General Hospital didn't report any data, but because they contribute part of the denominator, they are dragging the uptake in Goronyo ward. That's why we are having an uptake of less than 50%. And so we quickly go and see if you could take out General Hospital Goronyo or Balakozo Health Post if they are not supposed to be reported or they are not functional, for you to allow and see a good uptake in that ward and LG and subsequently the state. So moving into the next chart, we're moving to surveillance, and you would see that as I presented earlier on, this is demography, level of care displayed by secondary, primary, and tertiary. The secondary facility constitute about 88% compared to secondary facility 11, and then tertiary about 0.5%. And by ownership, you could see public constituting about 74%, and while the private about 26%. So you also have reporting by ownership. You can see the trend tracking which of the facilities are private and public reporting, then the level of care also, then consistency among the facilities that are reported more than 8 times in a year, the one that are being tagged to be continuously and consistently reporting. Then we have a good chart also presenting the 2018 drug therapeutic efficacy study results. We do have sites in the country that has Enugu, Kano, and Plateau. Then this is a national. So we have a chart displaying the adequate clinical and parasite cure rate. That's to say the efficacy of the drug. So we have corrected, which means PCR has been conducted to correct the issue of recrudescence and reinfection. So what we have a summary, if you looked at the molecules being tested, because we have the AA displaying as the light green. So and then we have AL, and then we have DHP. These are the molecules being tested. So if you looked at the corrected, which is the one that molecular analysis has been conducted to adjust the proportion of the efficacy. So you could see that AA still stands nationally, which is this. You would see that it's almost 98% efficacy. You can see AL standing for 98% as well. Then you can see the DHP standing 100%. So this is a very important finding for us, especially the correctors are the ones that you've removed reinfection through the course of tracking. So this is information that we're working on getting a trend that will show the efficacy of the drug over the years, whether or not there is a dip when you go along. So then moving into the morbidity and mortality page, we also have showing trend of the prevalence. This is a proportion of children under 5 that tested, I mean, that had malaria during the household survey at random with or without presentation of fever. So you can see the trend from 2010 having to be a national figure of 42, and it moves down to about 23%, which is a 45% decline over the 8-year period. So this is an achievement the program is tracking, making sure that we don't lose the momentum gain. So we also have a map showing disaggregation by state. So when you take a cursor close to the states, you will get to see the actual figure per state. So Kebbi State here is having a 52.2% of the parasite prevalence from the 2018 DHS. You take it to Lagos State, or you would see 1.8. Moving to Gombe State, 30%. You now move to Imo, 7.8. So you can just take the cursor it gives you, and it has a legend that we categorize based on the color shading. So you can see places where it represents dark green. You can see parasite prevalence between 42 to 52%. And there's only one state that has that parasite prevalence. Then you can see the second band, it has 32 to 42, which is 7 states, and so on and so forth. So we also track hemoglobin, low hemoglobin less than 8 grams per deciliter, data from 2010, 2015, and 2018 DHS. So we also a map representing the country for the 2018 DHS. You could see a value that dropped from 10% to 7.5% in 2018. Also have like a legend to look at how many states fall into the higher category and the other shading that follows. Then we also have a vector species distribution by LGA. This is also looked at the map. You can see percentage of dominant vectors in the country: Arabiensis, Gambiasis, Venantus. The blue now represents places where you have these vector distributions at about 65 to 100%, which constitute 516 LGAs that fall into that category, followed by an LGA in the red, which is just one high. Then you also have 9 that Arabiensis, more, and so on and so forth. So with next chart, we have what we call health system, where we try to present data that has to do with the expenditure on health. So comparing with the domestic and external expenditure, as you can see this bar beginning from 2000 up to 2016, percentage investment that has to do with malaria in terms of which this one includes the government of Nigeria, and then out-of-pocket expenditure as well. Then the external health expenditure, you can see as a percentage of health expenditure moving around 4% through 10. So the other chart here is out-of-pocket expenditure as a percentage of health expenditure. So you can see it keeps on fairly stable, average of about 43 at 75%. So this is a current health expenditure as a percentage of GDP. That's a gross domestic product. So you can see how much are being spent when you compare with the country's GDP. So you can see a trend of 4% beginning of 2000 to 2016. So you can also get a map of saying malaria funding per person at risk. This is per capita expenditure. So you can see, and then disaggregated by domestic and then international funding per capita. So towards I think 2016, you can see 1.1 of the funding is coming from the international support. So you can also see a trend of partner support. You can see representative blue, the Global Fund, the PMI, the USID, the World Bank expenditure. As you go along, you can see some coming in, going out. So this is the summary. So moving into the next one is the data validation. So we have, as I said earlier on, comparing data validations across the indicators of malaria, saying one shouldn't exceed the other. So the first chart here is showing out of outpatient division attendance versus the fever cases. So you can see we expected not to have this a national average comparing the state total. So you can see all of which is green. Green actually stands for those that are satisfy the criteria that fever cases shouldn't exceed OPD attendance. The same thing here is the validation of fever and testing. We said testing by any of the test types shouldn't exceed the fever cases, because you can see also this is green. And the next indicator is looking at fever testing. That's those that actually got tested shouldn't exceed confirmed malaria cases. That's why this green is showing. Then the next indicator is those that are confirmed malaria shouldn't, those that are receive ACT shouldn't exceed those that are confirmed malaria. So those are the checks. Then you can now look at those that are clinically diagnosed malaria given ACT. So we combine the confirmed and the clinically given ACT, and then we looked at to see. So because even if you are diagnosed using clinically, you will still expected to receive ACT. And then this is first fully immunized children and the LLIN uptake. You shouldn't have more children that receive LLIN than those that are fully immunized, because this is the denominator for or eligibility for you to receive the LLIN. So then the last one is the ANC first visit and the IPTP, because this you shouldn't exceed that. So you can see. So those are some of the data validation to assess for the illogical data we now plan. But the first thing is for you to look at it by facility, because anything you do aggregate data to either LGA or ward or state is going to dilute, because if facility has more outpatient, it will dilute the one that has less, and then you won't see what's happening. So we're going to quickly select the state at random to see whether or not health facilities are presented. So we're going to take state like Oyo State, which we do know that, and this time around it's only health facility. You're not going to see it by ward or LGA, so it's just going directly to the facility in the state. So we are comparing those data sets to see whether they do agree with each other. So it's booting currently. So it has come out. This is the total facilities in Oyo State. So you can see other thing is when you have a yellow, it means one of the data, one of the variable do not have data, so it's empty. So that's why you do have yellow. But then classical example, you can say Arafat Primary Health Care Center. It means the fever cases exceeds the OPD. You can see even if it's one, it will flag. And then you can also see here the same thing in the maternity and child welfare clinic, also the same thing. Bani, so Bani Health Post here too has 34 and 30. So all of which, whenever so you can quickly understand which facilities submit illogical data. You can follow up to find out what is it, and then correct it if possible. And then we can do a quick check again to see whether it is there. The same thing with the second indicator that we're tracking. You can see how facilities that do present more testing than the fever that presented. Going to the next, you can also see. So it provides you with a snapshot of, so you can see this is actually illogical. You can see Collier Primary Health Center presented those that are confirmed malaria to be 272, whereas those that actually got tested in either of the test type is only 48. So this will now provide you with either is it that something is wrong for you to also the same thing, those that are confirmed are receiving ACT. The same thing here, those that are clinically and then confirmed that receive ACT, you can see. Then those that are also looked at health facilities that have more ANC, more IPTP uptake than ANC visit. So you can see this is IPTP 1. We deliberately leave IPTP 1 than IPTP2, so that it's a ANC first visit that we're tracking. Eligibility here could so this is Oyo State. You can also select other state to understand what is and then do a follow. So here we are coming to Kano. You can just do a Kano. It's the same facility. Just click enter. So you can see each of the data elements. I mean, the variable you're interested in. The same thing here. You can see some facilities reporting 43 fever cases, higher 33 in OPD attendance. This one under Alajawa Health Clinic reporting 518 fever cases compared to 322 OPD attendance. So I think this is for me a very important tool. It provides at either national or subnational to quickly have a view of which facilities actually presented. So this is April 2020 data. We can also quickly go ahead and find out. So it helps us to narrow down which facility to visit during the QA, and then which one do we even need to do a follow up or maybe phone call or understand what is actually happening. Maybe the LG M&E officers in places where it's a few numbers perhaps made the mistake, so he could quickly validate and then go into the DHIS platform and change this data element. So I think this is the few demonstration. I mean, once you do a hands-on, you would understand and implement better than or what we present. So these are the six dashboards that we go through it. So we are now going back to the presentation. So then, so as a form of recap, you remember we were able to discuss the thematic dashboards and their names based on the indicators they are tracking and the variables they do track. And we also have discussion around the charts and the maps, how we can use that to make decisions using the drill that function. And all these things are being done to demonstrate that we can use data and there's a very quick access that we could use to navigate across different organizational units, be it the states, the LGS, and the health facilities, and you can take decision. And this allows, at whatever level you get yourself in, it provides you with information that you can take a very quick decision. And you can imagine the commissioner or any policy maker having access to this data. He can quickly follow to monitor what's happening in the LGA. I mean, assigned responsibility for them to go and address those issues. I think this is a recap. So we do have exercises at the end of the presentation, which is just for you to go through what I did in the presentation so that you can now answer this practice questions. So we have a couple of them here, up to 8. So I think during the Q&A session, we'll be able to answer this. But before that, once you watch this video, you should be able to go through and answer this question. So I think, yeah, so this is, uh, um, thank you very much.